Okay, so thank you everyone for being here today, and good afternoon to you. So this month we are doing a COYL Partner Meeting, but more in honor of National Healthcare Decisions Day. Thank you. But I wanted to just start off for anybody that is new to COYL or needed a refresh. COYL, or Conversation of Your Life, is an initiative of the Mayor's Wellness Campaign that aims to provide communities throughout New Jersey with resources, educational programs, and connections to subject matter experts and speakers on how advanced care planning is an essential part of health and wellness. So we aim to really empower our residents to discuss, document, and share their healthcare priorities with the people that matter most to them, their healthcare proxies, and their healthcare providers to ensure their voices are heard in the case that they are unable to speak for themselves in a medical emergency or due to a serious illness. And so April 16th is National Healthcare Decisions Day. All across the country, healthcare facilities, healthcare professionals, chaplains, the legal community, and others will be participating in a collective effort to highlight the importance of making advanced healthcare decisions and to provide tools for making these decisions. If you go to the NHDD website, you can learn more about that and see what resources they have available. And just when it comes to COYL, there are things that we're asking you to do in honor of National Healthcare Decisions Day, right? We want to start the conversation. We want to encourage people to reflect on their values, choose a healthcare proxy, and document and share their preferences before a crisis happens. And COYL can help communities encourage, you know, having these discussions by saying, like, by hosting a COYL event in your community like this one, using our COYL community messaging toolkit to share about the importance of sharing your wishes via social media or a newsletter, and encouraging your mayor to sign a proclamation recognizing National Healthcare Decisions Day. So in honor of doing so, we wanted to offer a presentation on a lesser known but deeply meaningful option that some individuals may choose at the end of life, which is medical aid in dying. Elizabeth Stanton is going to be our presenter today. She brings both professional and deeply personal experience to today's conversation. She is the co-founder of Compassionate Endings New Jersey, which is a medical practice dedicated to supporting terminally ill individuals who choose to utilize the medical aid in dying process. So together with her partner, Dr. Robin Plummer, Elizabeth has supported over 250 aid in dying days and helping individuals with both the MAiD process and symptom management at the end of life. Her background includes emergency department and critical care nursing, end of life care, and teaching as a professor of nursing. So I'm really honored to welcome Elizabeth here to share her insights and experience and to help deepen our understanding of this important option in the spectrum of end of life care. So I'm going to pass it over to you, Elizabeth.
Thanks, Katie. Hello, everyone. Thank you so much for having me. I'm going to share my screen. Just I do have a PowerPoint, which I will use as a guide here. 1 second. Okay. So I'm going to talk about what's medical aid in dying. And, there may be a lot of people in the audience that are not familiar with it. Some of you may be. It's not always the most comfortable topic to talk about. And I'll be honest with you, it wasn't for me initially. As Katie said, my background was ER and ICU and a bunch of other things in between that. And, my comment to patients or my directive was like, okay, I'm going to make you better. We'll fix this. And, that paradigm had to change when I transitioned over to end of life care. And I will tell you that changed from, we're going to fix this to we're going to honor your wishes and we're going to keep you comfortable and make you better, make you feel better. We're not going to cure the disease, but we're going to make you better. So it was my patients, those first few patients that actually said, Elizabeth, you've got to be comfortable saying that and talking about death. And I said, and thankfully to them, I did become more comfortable. And as time went on, I began to really understand just how powerful and important end of life care is and what medical aid in dying, for those who choose it, what it offers. So I'm going to talk about it. I'll discuss it. I'll take questions. Feel free to ask any question. I'm happy to answer. So, a lot of times people say, what is a good death? And you'll hear, a lot of times we hear it at, a funeral, people say,
Sorry,
oh,
Elizabeth.
he died in my sleep. He died in his sleep. And that's the first thing people say, well, just let me die in my sleep, to be at home and not in a aseptic hospital with monitors going off and strangers walking in and out of your room. They want their family and their loved ones next to them, near them. They want to be able to have the chance to have a true conversation with those that they love and say, I love you, goodbye,
Oh,
and thank you.
I'm so sorry to interrupt,
No,
Elizabeth. Your slides aren't up if you wanted to
oh,
use them right now, but I just
I
wanted
am
to.
using it. Okay, wait, hold
Yeah,
on. Oh, I'm sorry.
that's okay. It happens.
Let's see. Share. Is that okay? It says I'm screen sharing now.
Yeah, but
Oh,
it's your Zoom.
okay, good. All right. Sorry about that, guys.
It's okay.
Um, so let me go back. Oh, just get there.
Great. Thank
There
you.
we go. Okay. So now we're back on track. Okay. So as I said, to have the chance to say goodbye, to say thank you, it also is the chance that my partner and I have seen a lot in that we see fences being mended, the two sisters that haven't talked in 20 years because she stole her date, or they don't even know half the time what they fought about, and they just know that they were mad at each other and they haven't spoken in so long, and they find out that their sister is terminally ill, and it brings people together and they have the opportunity to say, look, wow, I wish all that time didn't pass between us, and thank you, and I'm sorry. And it's actually quite a beautiful thing. They want to be pain free, which is a good expectation. And obviously to be treated with dignity and respect and maintain that dignity and respect to the end. And a lot of my patients will say, I don't want my children taking care of me when I soil myself. Understandable. So by definition, medical aid in dying, what is it? It's a medical practice that enables a terminally ill, and I'll get into these definitions for you, terminally ill, mentally capable adult who has an expected prognosis of 6 months or less to live to request a prescription from a physician, a licensed New Jersey physician, for medication that they can self-ingest to allow them to die peacefully in their sleep. That's the Reader's Digest basic definition. So why do people choose this? It's not for a lack of pain control. Many of our patients are enrolled in hospice. We encourage it. Hospice is very good at pain control. Um, it's not that, but they have a strong desire to maintain that dignity until the moment of death. And when they feel that they are losing that locus of control, that whatever that disease is that has taken away that control in their life, that's when they say, then it's time. And what we have noticed, it's a very unofficial survey. I will tell you, there's no statistics behind it, but most of our patients, we see that there's just a very typical personality trait in our patients. These are typically your caregivers, the people who are used to taking care of others. And it's such a shift for them to be on the receiving end of care. It's sometimes harder for them. They're like, I don't get this. I'm supposed to help you. And they're very independent. What we have determined, we kind of coined a quality trait from the beginning, and that they are resolute in their decisions. They don't waver. It's okay if they do, but typically they don't, and they're very resolute. And they like to be in control. And these people are dealing with a disease that has taken away their ability to choose things, taken away their ability to do what they want. And medical aid in dying just gives them that little bit of control. I can't control the fact that I'm dying, but I can control the when and the how. And that helps. So people say this a lot, and you will see it written up, but a lot of times journalists use this. I'm sorry, and if there's any journalists in the audience, forgive me, but is MAiD just another term for physician assisted suicide? The suicide part is just no, absolutely not. Okay. Physician assisted suicide or euthanasia? No, it is not. People say we treat our dogs better than we treat our people because, dogs can be put to sleep. Well, the difference is that the dog doesn't have any say in it. Okay, we determine that. With medical aid in dying, it's the patient that drives the bus. It is that person. They make those decisions entirely on their own. And I will tell you that we make sure of that at every juncture that we have communication with the patient. But a lot of people still will say, oh, it's suicide. So what is suicide? Well, suicide involves the choice between living and dying. When you're terminally ill, there's no choice. You know that you are dying. MAiD just gives you, as I said, the when and the how, right? Um, Oftentimes we'll see suicide can be impulsive, it can be violent, often happens alone, which, as you see, I just said, with medical aid and dying usually doesn't. Oftentimes, and my partner and I have walked into homes where there's 50 people in the home, and it's beautiful. They've turned it into a celebration of life. Some people have just one or two people. There are a couple people who said, no, I just want, you guys here. I just want to be alone. All right. And we respect whatever people want. And with suicide, it's often very traumatizing to those who are left behind. People, we that survivor's guilt. What could I have done? Why didn't I listen? Why didn't I pick up the phone the last time they called? With medical aid and dying, we know that the death is going to happen within 6 months or less, roughly. Please know that a prognosis is an educated guess. So sometimes it's longer, sometimes it's shorter. They are not choosing to die, a disease is choosing it. Okay. And they're just basically choosing not to prolong a painful dying process. The person must be mentally capable, meaning that they must be able to make their own medical decisions. Usually, as I said, the loved ones have a chance to say goodbye, and it's actually quite beautiful. And I have been privileged and honored to have been a part of so many people as they have said goodbye to their loved ones, and it has stayed with me in so many ways. And typically medical aid and dying is not done in secret. There are a few people that they choose, I'm just going to tell one or two people, but I just don't want an audience, and that's their decision, and we honor that decision. So some of the terminal illnesses that we take care of include, but are certainly not limited to, metastatic cancer, which is probably the highest percentage that we see, followed pretty closely by neuromuscular diseases like ALS or Lou Gehrig's disease, any kind of advanced heart, liver, lung, kidney disease, so some Parkinson's disease, sometimes provided that there's mental capability remains. So, and there's a few other diseases that we look at independently, but that's the big example of most of them. So who's eligible? How do you become eligible for this? Well, first of all, if you are the patient, you have to make the decision. Somebody can tell you about it, like me, and say, this is offered in New Jersey and it's legal, but you have to be the one that says, this is what I want. And we take painstakingly time just to make sure that we know that this is what you want. Okay. You have to be an adult. You have to be a resident of the state of New Jersey with a terminally ill prognosis with a 6 months or less diagnosis. Once again, mentally capable to make those decisions and no coercion. And that's another thing that we follow. But now medical aid in dying has been around in it for almost over, I think a little over 30 years in the United States, but primarily on the West Coast. And I'm very thankful to our West Coast healthcare providers who have forged the way for us, who have figured out the best way and the most humane way and the right way to do this. And they have gone through many iterations of medications and processes to come up with what we use today. And it's been legal in New Jersey since 2019. So still relatively new. Patient must be able to physically self-ingest the medications. Now, a lot of people will say that means drink. And yeah, most of our patients do drink it. There are other methods. You might have to use the gastrointestinal tract. And if we all know there's an entrance and an exit. But as healthcare providers, we know that the exit can also be used as an entrance for medication delivery, provided that the patient can self-administer. And there's a process to that. We don't need to get into it. It's minor, and the patient still will administer it themselves. It's just the different route. Okay. And usually we'll do that if there's problems swallowing or there's problems in the upper GI tract that we worry about absorption. Okay. Couple caveats that people always ask, well, life insurance. If this is, am I allegedly taking my own life? Are they going to say my life insurance isn't covered? Life insurance is completely unaffected, and that's specifically written into the law. Also, on the death certificate, whatever the terminal illness is what's listed as the cause of death. So the life insurance company wouldn't even know about it anyways. But even if they did find out, it is specifically spared. So who knows about this if you're taking it? You. The only people who know that someone chooses medical aid in dying are the ones that the patient chooses to tell. We don't tell. We honor what you want. Okay. It is important to know that the cost of the medication and the care of the person using medical aid in dying are not covered by most insurances. So, there is a cost involved, and people need to know that going in. So what's the process? So I'm gonna do this a little quickly because we'll go over it, but we take care of this for the people. So an attending physician who, if you were with us, would be Dr. Plumer, my partner, can take what's called the first verbal request after we determine likely eligibility. And the patient will call and maybe they'll talk to me and they'll give me a history and tell me what's going on. And based on what they tell me, I can sort of determine whether or not this is terminal and what the likely prognosis is. And I will pass it through, talk to my partner. She'll say, okay, well, let's talk to them. And usually we will try to set up a meeting that day, usually a Zoom meeting if they're geographically far away, or we'll go to their house if they're relatively close. And the reason we try to set it up as soon as possible is because there are time constraints placed on, how quickly this can be done. And oftentimes, um, some patients, by the time they get to us, they've been looking for a physician to help them with this for quite some time, and they haven't been able to find them. And they're towards the end of their life, and they're wanting to take the medication sooner rather than later. So taking that first verbal request essentially starts the clock. Okay. Because a minimum of 16 days has to elapse between that first time we talk to them, that first verbal request, and the second, what's called the second verbal request. First and second requests are exactly the same. We ask you, what is your diagnosis? Do you understand that this is a terminal diagnosis? Are you doing this of your own volition? Is anybody trying to, talk you into this? Do you understand that once you start taking the medication, you can't stop. Anytime up to that moment before you take the medication, you can say, I don't want to do this. And I will tell you, I've had patients and I tell them, look, if we get to your home that day and you say, Elizabeth, I'm not feeling it today. Not today. Okay. You tell me when. I'll go home and you tell me when. And we'll come back. And if that day isn't good, this is a big decision. It doesn't happen often, but we absolutely would respect it. Only a physician can take those requests. In between those 16 days, a lot of stuff gets done, and we really do get to know our patients. We never want that first time for them to see us in person to be like one of the first times that they're talking to us. That's just not right. That's not right on the day that they're taking their aid in dying medication. We want them to know that the person that myself, my partner, we have another physician partner, Dr. Danzig, that we care about them and that we are vested in their care and their wishes, and they feel comfortable with us. I joke we're going to be on their Christmas card list. We know the pets' names. We want to know them. So in between those 2 weeks, we have a lot of communication, paperwork, fortunately, and there's also a state form that has to be filled out. It's called the written request, and it's called to end my life in a humane and dignified manner. It's on the Department of Health website, but we give it to the patients, and it just has to be signed and then witnessed. The signatures have to be witnessed. One of the witnesses can be an immediate family member. The second person can be anybody that doesn't have a vested interest in the estate. Just another kind of stopgap to avoid coercion. And I tell them it can be your mailman. As long as he can say, yes, I know who this person is, that is her signing it, and they can sign it. Okay. There's also in those 2 weeks a consulting physician, meaning a second opinion, and they get the chart, they get their medical records, they look them over, they have a meeting with the patient, whether in person or via telemedicine. They speak with them, and it's pretty much the same as that first request. They make sure and they have to confirm the diagnosis and the prognosis and mental capability. So, as I said, both physicians have to determine that the patient is not being coerced. And as I said before, and I just want to reiterate it, that the individual can rescind the request up until the moment they start to drink or ingest the medication. Once that starts going in, no, you can't turn back. It's the medication is very, very, very potent, obviously. So even a small sip is possibly could end their life. So we always make sure that we. So how do we get the prescription? So once all the qualifications have been met, paperwork's done, 16 days, and we get the written request. And as I said, we try to get the written request somewhere in the first week because 48 hours has to elapse between receiving the written request and obtaining the prescriptions. It's not usually an issue because we get it early. And once all of those requirements have been met, the physician can write the prescription for the aid in dying medications. Some special situations that we are always alert for, we will assess a person's ability to swallow, their GI system health, if they've had multiple surgeries or they have what's called like ascites or a lot of swelling in the stomach or tumors, or they haven't eaten in so long that the intestines are just not really able to absorb the food or nutrients as much. These are things that we have to consider. But we can take care of people with peg tubes, colostomies, and as I said, there is rectal administration, as long as it is used through the GI tract, okay, and the patient self-administers. Big question. Okay, so how long does it take for someone to die? And that nobody likes to talk about this, and I get it. But once the medication is ingested, within 2 to 5 minutes, the individual will fall into a deep, deep sleep. You hear on the news that the person is in a medically induced coma. That's kind of what it is. I liken it to anybody who's had surgery and the anesthesiologist tells you to, count back from 100, you get to 98 and you open your eyes and say, whoa, hey, when are we going to get started? And they say, it's all over with. And you don't know anything happened. Now, the difference is you don't wake up. That's the purpose of it. Once the deep sleep sets in, the person has no sense of pain, no sense of anxiety. It is just that deep, deep sleep. About 80% will die within 2 hours. Okay. 90% within 5. Now, that leaves 10%. So there's outliers. Some can take longer, and it has happened. But the thing is that nobody wakes up. You don't wake up. You don't know that it's taking longer. The family is there. And that's why, my partner and I believe that a trained professional always should be with you. We don't know of any other practice that does this, I'll be honest with you. But we're there. We've already educated our family. They know that, yes, it can take longer, but it's okay. We're here. We'll explain things. We explain the process of death. We're there to normalize it. And we're there on the crazy out chance that if something happened, we know what to do. I will tell you now, we are many, many years together, ER based. And if you know anything about ER people, you can't surprise us. You can't shock us. We get it. We don't startle easily and we know what to do. Because that's why we're there. We're there to act in an emergency and act appropriately. Very rarely does it happen, but we're there just in the event that it does. I will say when I went into people longer, there are people who've gone much shorter. I had someone who fell asleep while drinking the medication and passed away about 90 seconds later. And that does happen also. And I'll be honest with you, can we tell? Not always. We look for those red flags, but we don't always know. But we do always know that we're there and we'll make sure that you stay asleep. We usually never have to do anything. We never have in 5 years. And we've attended probably about 250 aid and dying days, if not more. So when we want to keep it that way. So 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 as I said, why are we there? Because something can go wrong. Well, the law does not require, and it bothers me. It bothers me so much. And I don't think a medical person was consulted while doing this law. I really don't. That no medical person be present on the day of ingestion of medical aid and dying medications. I don't agree with it. I don't. And look, and we're an unbiased party in the sense that while we do care about our patients, we also can be objective and we know how to act when the time comes to act. If there's nobody there, people can spill the medication. It can be incorrectly mixed, and there is a specific way to mix it. What if the person vomits all or some of the medication? What do you do then? If there's a delayed time until death. Now, the family says, okay, well, Elizabeth said, 80% within 2 hours, 90% within five, well, we're on hour 6. What did I do wrong? Should I call 911? Did I do something wrong? They start to panic. Doesn't need to happen. Oftentimes, family does not know when to determine when death occurs. And that's happened frequently. I've had family members say, okay, she's gone. No, she's not. Just give it time. I promise you. I'll let you know. I'll tell you. You just sit there, hold her hand and love her. That's all you have to do. I have to be honest with you, and as much as I am a proponent of medical aid and dying, I don't know if I want to be the one that mixes the medication that my own mother is going to drink, that I know is going to end her life. And I don't think a daughter or a son or a family member, a loved one should have that responsibility. It's my own opinion. We kind of give the family members the loving, the comfort things to do. We do sherbet and sorbet in between, kind of cleanses the palate. And I will say the medication doesn't have a good taste. I know that. So we do everything to kind of mitigate the taste. And we have the family members do that because that's a comfort and we want them to be providing the comfort. There is also the potential that, you know, the sister who hasn't talked to her sister in 20 years finds out that this is happening. They didn't mend fences. They come flying in, see what's happening, and say, "Oh my God, you're trying to kill my sister," and calls 911. And then it's an entire mess. It almost happened once. Thankfully, I was on the phone with the people and I was able to get there in time and talk to police, fire, ambulance, medics, and we got everything sorted out. But it can happen. It wouldn't happen if we were there because we would have handled it. So it's just something to think about. So some of the roadblocks that people say, and as I said earlier, where have you been? We've been trying to find you. We've been trying to find a doctor that will do it. And as hard as we try, we still end up on page 2 of Google, sometimes 3. I don't know why. It just happens. But finding an attending doctor that's willing to do this, because not every doctor is willing to do this, and no healthcare professional is forced to participate. Doctor, nurse, social worker, pharmacist, no one, if they have an aversion to it, they ethically, religiously, whatever, they can say, no, I don't want to do this. And that's fine. And you don't want them doing it because you want somebody that's going to support you in what you're doing. So I'm in complete agreement. Finding a pharmacy, it's a specialized pharmacy that can do this. It's a compounded medication, so it needs a specialized compounding pharmacy. And there to date are only 3 in New Jersey. And if you want to know how I know this, I very diligently spent about, I don't know, at least 10 days of my life calling every pharmacy in New Jersey, from Cape May to all the way to the tip of Bergen County. I everywhere. And we have fostered 3 fabulous relationships with these pharmacies who are appropriately spread out through New Jersey, so it kind of works. And they know our patients. They know that the, that it's time sensitive. They understand what this is about, and they are very respectful and very responsive for when our patients want to get their medications filled. And I will say, once you qualify, you're always qualified. But we send in that prescription to the whatever pharmacy, and you know what pharmacy it is, we tell you. Um, the prescription's only good for 30 days. You say, wait a minute, what do I do then? You know, we take care, we refill, we renew it every 30 days. You'll never have to worry. You will always have, the person will always have a current prescription ready and available to them. So that's not a concern. If they find somebody, a doctor, their family doctor maybe says, oh, okay, I can help you. I'll do this. Um, finding someone who can do it, who'll walk you through the entire process from the first request till death and provide some follow-up with the family. I will also say that in the law that it does not specify what type of physician can write the prescription or take care of a person. And while I have complete respect for all the physicians that I've worked with, I don't want a plastic surgeon writing prescription for end-of-life medications. They don't know how to do it. They don't know what it is. It is a specialty unto itself, and it will hopefully become a true specialty in a few years. But you want somebody who is experienced and knows the science behind it and knows the process. But once again, if your dermatologist can write that prescription, if so inclined, don't do it. So hospice. Most of our patients, we get a lot of referrals from hospice, and conversely, we make a lot of referrals to hospice. We highly recommend that our patients are on hospice. For many reasons, they add a layer of support that just no one can compare. They are wonderful and they are responsive. And they just add that added layer of support. And we work with hospices, any hospice. We develop a relationship with the nurse, the doctor. We converse frequently. We offer advice on end-of-life symptom management. We've got a little more tools in our toolbox sometimes that helps. So, and also, if there is a death that occurs in the home, and it is not, the patient is not on hospice, it is considered a medical examiner's case until proven otherwise. If it's a hospice person, then it is not. If they're not on hospice, you have to call, you do the 911 with the police, fire, ambulance, all those bells and whistles, everything that our patient didn't want. So we very much encourage hospice involvement. So some of our data to date, our general time to sleep has been about 5 to 10 minutes. Our average time to death, 2 to 4 hours. Okay, and our patients have been asleep the entire time. No one has ever woken up. Our shortest time to sleep is 2 minutes. And actually, I have to update this. Our shortest time to death is 15 minutes. Mine was 2. So it was very quick. So I'm going to just give you a little information about us. This is not in any way a commercial for us. You don't have to be our patient. We'll still answer your questions. We want people to get this right. We want people to understand what it is and have the right information, because so often there is not the right information out there. So we are a specialized practice and we are the experts. We are the de facto go-to people in New Jersey. I spoke at the National Convention conference in Portland. My partner is one of the, they call them the hot docs, the top docs. She is on call for other physicians throughout the country, other healthcare practitioners, to bounce their ideas off of her, their questions. She's the one, she's considered the expert. So we know what we're doing. Our practice is specialized. We focus solely on medical aid in dying. And we assist our patients up to and including the time that they take the medication. And we do help with symptom management at the end of life. And as I said, we have a couple of extra tools in our toolbox that sometimes people don't think of, and it helps. We do offer alternatives for those who cannot drink the medication. And as I've stated, we attend all aid and dying days in order to be sure the procedure goes smoothly and support to the family. And that is from 2 minutes to 2 hours to 20 hours. It doesn't matter. We're there. Um, this is an intimate and honorable and giant event in people's lives. And as healthcare practitioners, I think that, especially nursing, I will say, because we kind of change, we'll go around in different specialties, oftentimes kind of try to make ourselves jack of all trades, maybe master of none, but we're there oftentimes when with the first breath of life with a baby, and we're there with the last breath with the terminally ill patient or other situations. And it's such it's an honor to be at both and everything in between those dashes. Um, and we take that honor very seriously. And that's the best way that I can say how we practice. And as I said, doesn't matter if you come with us or not. If you call me, I'll answer your questions and I'll guide you, as will my partner. So this is some information, our direct information about us. Um, we're located in Charlotte. We don't have an official office because our office is our patient's house. We come to you. So it cuts down on our overhead, which is nice. But then there's our mailing address, and we have our phone number, and we also have a website. It's compassionateendings.nj.com. The website is really not as much an advertisement for us as it is, a rundown of what medical aid in dying is and what the process is, and a lot of what I just said, but even more so. So if you're interested, if you have questions, I ask you to call and we will happily answer your calls. So I will open this up to any questions. I don't know, I'll take this down. And I know Katie will also have our information if you, you want it, but, so I'm going to stop my screen share so that I can see you guys. And please, any questions, I welcome them.
Yeah. Thank you so much, Elizabeth. Oh, Sarah, I saw you on mute, so go for it. Sorry.
Hey, Sarah.
Hi, I'm Sarah. I work with Beata. Couple things. I first want to just say thank you for this. I work in end of life care. I educate the community on, uh, resources and what this means, and it's hard for us. I can imagine when you're talking about medical aid and dying, how a whole nother layer of difficulty. I am so happy to be living in a state that honors the wishes of those who, want to have a little bit more control in their last days. I am a huge advocate and supporter of any and all support of end of life. I'm an end of life doula, so I
Oh,
moonlight.
okay. Wonderful. That's wonderful for us to know.
Yeah, so I'm very passionate about providing support and care to those who are end of life. I had a question. The attending physician. So that attending physician is the physician who is going to be writing the order for the prescription of the medication, right? And that is someone that we would have to find, the person themselves would have to find someone who would be agreeable to that. And it wouldn't be your doctor. It would be a separate physician. Is that what I'm
No,
understanding?
we are the attending physician.
You are the attending
Yes.
physician.
And the consulting physician, we try to use the patient's own physicians, their GP, their cardiologist, oncologist, and we have a lot of luck with that. And they already know the person, so it helps. But sometimes they're a little reluctant to do so, and we respect that. Also, sometimes facilities don't permit their employees to do it, and we
Right.
sadly respect that, but wish that they would be a little more proactive. And if that comes down to it, then we do have other independent hospice physicians that we work with who will act as a consulting physician, but it costs money. And we do try to save the patient money where we can.
Okay. All right. I'll probably reach out to you.
Please do.
Just to pick your brain a little bit more and understand a little bit better. Do you utilize end of life doulas?
Absolutely.
Okay.
Absolutely. I've worked with them probably from day one. I didn't know that you existed. I only knew like birthing doulas. And my eyes were just opened. And after working with many of you, I just thought, my God, what a gift. If anybody has the opportunity just to pick Sarah's brain as to what she does, it's a beautiful thing. And I thank you for what you do. So please know that.
I know I like, again, I work for hospice, so trying to get that hospice on board with utilizing, that
Mhm.
additional support is a challenge. So, I honor and respect, all that you do and appreciate you for providing this information. This is invaluable education for all of us. And we do get questions out there from patients that are asking us as well and picking our brains about medical aid and dying. And there's a lot of misconception around there, just like there is with end of life care in terms of hospice. So it's nice to know also that we can also work so closely together from like a hospice standpoint for that additional support, as well as you and your knowledge and providing something to families and patients
Mhm.
to
Thank
give
you.
them back their control. So thank you. I really appreciated this.
Thanks, Sarah. Keep doing what you're doing.
Ted, I see your hand up.
Elizabeth, really, thank you. I didn't know that your practice existed. That's really cool. I have been kind of following this for years since the medical aid and dying legislation was coming through and finally enacted. And I've done my own journey. So I'm a healthcare chaplain as
Okay.
well as a clinical ethicist. So I've kind of done my own journey over the years on trying to understand this and take it in. So I do have I guess a ethics-based question on this, which is not what you might usually hear from a religious person. It has nothing to do with the
Well, go ahead.
morality of it. It's the morality of the access to it. So that's always been my concern, is that it costs money to access your practice, to receive the medication. There are a lot of people who might want to take advantage of this who might not have the financial resources to have that option. To me, that is an ethical problem.
I completely agree, Ted. And it's something that we have struggled with, I will tell you. And statistically, the typical patient is usually college educated, more upper middle class and above. We have had people who are financially struggling, and we have worked with them. We've provided sliding scales. We also have been very blessed. I want to use that with you to say that. To have a family of a former patient who started a foundation for us, for our patients, for they would pay for the cost of the medication, which is almost $1,000. We don't have any control over what it costs. And they have in most cases paid for the entire prescription for them. And we've also, as I said, we can't give everybody a discount, but we absolutely work very hard to make it work.
So I guess that would be my question, if you don't mind me asking as a follow-up. What would, if someone came to me and said, well, what does it take to get this done financially? What would be the kind of the least cost that someone would have to go through? And you're saying already there's $1,000 on the table just for the medication.
Yep. So it's usually my first question, and I usually don't include it in my talk because I know somebody's going to ask it, and I'm fine with it. We have to make money.
Help.
Yeah, no, thank you, Ted. So look, we have to make money. We have to put food on our tables too. So our cost is a flat rate. It's $6,000 from beginning to end, and that's whether they're with us 2 weeks, 2 months, 2 years. We don't ask for more money. And as I said, a lot of times I'll get a call from a nurse beforehand. They'll say, look, I have this patient. Yeah, they're both on Social Security. That's it. Can you do anything? And I'll be honest with you, we're healthcare providers. Yes, we usually do. And look, we've got soft hearts. We try to work with people as best we can. And we managed to make it work. And it's offset because also a lot of our patients are able to pay our rate. But we do try. It's hard to look at a dying person and say no. It's just hard,
And I get
and
it's not, I understand this the way our system is founded, and people do have to get paid, and that is your professional time and energy and expertise. It
mhm.
just, to me, a bigger system issue that we don't have a funding mechanism to do this, and so it is private pay, which really excludes a lot of people.
I
So
agree.
it is
I
it's going to
completely
be
agree.
wealthy white people who take advantage of this.
That is the demographic. That is the demographic that we see the most. Not going to say that it's all of it, but and that's statistically throughout the country. So, there is it's I don't know if it's a practice, but it's Death with Dignity, New Jersey, and I believe they don't charge, but the care paradigm is a little different, very different. And a lot of times we have been called in after the fact to say, you know what, we've got the prescription, but we don't want to go through this alone, and we need a little guidance, somebody to hold our hands. And a lot of times we'll try to help out, but it's basically they see the patient and they're competent, make no mistake. But they do their 2 visits. Here's your prescription. Go with God, and we're done. But that's not how we work, and that's not how we can work.
So I'm passionate about this too. If you guys don't mind me asking one more question, or just
I don't have a limit. I'm good.
well, I was going to say that to Katie too, but she can just cut me off, if she needs to. But so my sister is doing a lot of this kind of education work. She has a nonprofit in Maryland. I'm really proud of her. Somehow the two of us are doing end of life work all the time.
Wow.
But she made me aware that 5 Wishes organization really has taken a shift against medical aid in dying. I don't know if you just saw that recently.
I'm not aware of it, but I've heard a couple other organizations.
Yeah, their new CEO made a big deal about it. It's on their website. They're not using MAiD language. They use physician-assisted suicide language and everything. And so they're skewing their materials, which I've always enjoyed using, very much against this choice. So for all of us, being aware that that's now part of the landscape that we're doing.
Yeah, look, the current political climate is such that some of these programs are facing cuts with a chainsaw possibly, but we have to be aware of that. But I will say that there is a strong base in our legislature that is very supportive of medical aid in dying and all end of life options. And there is some legislature not passed yet, but mulling somewhere on that Capitol Hill in New Jersey, that to do other things with medical aid in dying, helping shortening the waiting time if necessary, and maybe getting some funding, different things. So I'm hopeful. I don't know if that's going to happen in the next 4 years, but I just hope that patients still have this choice. So
Thank you.
thank you.
Yeah, thanks for the great questions. Also, I saw that Patricia had put a question earlier in the chat, and it says, what about VSED? This is prolonged. Do people who do not qualify try this option?
So VSED is voluntary stopping of eating and drinking. It is considered an alternative for people who do not qualify for medical aid in dying, whether it's the prognosis or the diagnosis doesn't necessarily support the parameters of medical aid in dying. It is an option. It's a difficult option for both the patient and the loved ones to do, but it involves basically completely stopping eating and drinking. And not so much the eating is the problem, but drinking. And it's very hard to see somebody die of dehydration. We have assisted a couple people, not many, with VSED, and they have been successful. We've provided medical oversight and management. And it is doable. It is something that is there. It doesn't need a law to pass. It's the patient's own volition, whether or not they choose to take food or water. So yeah, it is something that is done.
Right. Thank you so much. Any other questions? Okay. right. So we're just gonna kind of wrap everything up, but again, with Elizabeth's permission, I'll send out in the follow-up email her contact information in case you have any additional questions. I also encourage anybody that is doing a presentation or event in honor of National Healthcare Decisions Day to send it my way so I can send it out to the rest of the COYL partner list and let them know what's going on in the state. If you aren't on our COYL partner list, feel free to fill it out. Isa dropped it in the chat. We really appreciate you working with us through conversation of your life. And our next COYL meeting is going to be on July 10th at 12 p.m. If there is a topic, by the way, if that you're interested in learning more about or would like to hear more about or would even like to share about during our meeting, we'd love to have you. So feel free to shoot me an email. Other than that, I just wanted to say thank you so much, Elizabeth, for being here today and really presenting us this great information.
For having me. I appreciate it.